Okay, we'll go ahead and get started. Hello and welcome. My name is Ryan Tappy and I work with the ALS Association. Thank you for joining us for another installment of our Living with ALS webinar series. The title of today's webinar is State Advocacy, Why It's Important, How Your State Measures Up, and How You Can Help. There are a few things we want you to know before we begin. First off, please know that you are muted and not on camera so you can relax and enjoy the presentation. There will be time at the end of this webinar to answer questions. You should see a chat box feature on your screen as well as a Q&A feature. You can use either of these options to submit questions you may have. All messages submitted will only be viewable by the host and panelists. We will review and answer these questions with our speakers at the end of this webinar. We do have a very short survey we're asking that everyone complete after the webinar. The survey will appear in your browser once the webinar ends. This survey helps us to know your thoughts on this presentation and topics you would like us to consider in the future. Lastly, this webinar is being recorded and will be available on our website in the Care Services webinar page within about a week. As many of you know, May is ALS Awareness Month. A large part of raising awareness for the ALS community and the ALS cause is advocacy. The ALS Association is at the forefront of public policy, working to improve the lives of people living with ALS and their caregivers. We're fortunate to have an amazing advocacy team that focuses on educating and mobilizing policymakers in a nonpartisan fashion to achieve our mission, to make ALS a livable disease and cure it. Today's discussion will focus on advocacy efforts at the state level and how each state is performing. Leading our discussion today will be our Vice President of State Policy with the ALS Association, Alex Meixner. Alex will be joined today by additional members of the ALS Association advocacy team, including Managing Director of Advocacy, Clark Hansen, Managing Director of Advocacy, Diana Arevalo, and Director of Advocacy Engagement and Mobilization, Dustin Purchell. So without further ado, I will hand it over to our speakers and I will return for the question and answer after the presentation.
Thank you very much, Ryan, and thanks everyone for joining us today. This should be a good and lively discussion of state advocacy. And as the title says, why it's important, how your state measures up, and what you can do to help. So let's dive right in. I will go to the next slide here. There we are. All right. So as we begin, what does state advocacy mean? Most people, when they think advocacy, when they think lobbying, they picture Congress in DC. And I get it. I understand. As I look at my team here, we've all one way or another worked on Capitol Hill, done federal advocacy along with state advocacy. We've got more decades of advocacy experience than we'd probably like to admit. But I'm here to tell you that state advocacy really is an important way that you can raise your voice and make a difference where you live. As we think about our motto that Ryan just said, right? We're going to try to make ALS livable and cure it. The governmental work to cure ALS, that'll largely take place at the federal level, right? That's the research funding, that's the NIH funding, the CDC funding, the different medical research that our federal government is so important has such an important role in funding, and that we're working real hard right now with your help to maintain and hopefully increase that funding as we move forward. But the business of making ALS livable, that to a much greater degree lives at the state level. That's something that we work on with your help day in and day out in state houses across the country. And really, those are some of the most impactful policies that you can help us achieve for the ALS community. So as we're looking at state advocacy, one thing that's important to know, it's not a one-size-fits-all arena, right? So as you see in that map, we've got some states that are what you would call blue, that have Democratic majorities in both chambers of the state legislature and the governor's office. We've got a number of states that are exactly the opposite with Republican majorities. We've got several states that are mixed, that might have a Democratic governor and a Republican legislature, or a Democratic Senate, but a Republican House, where there's got to be a little bit more bipartisanship. And then we've got Nebraska, always unique, that has a unicameral, nonpartisan legislature. So they don't have a House and a Senate. They've just got the one chamber, and there are no partisan titles attached to them. So again, there is kind of no one-size-fits-all reality of state advocacy when you're trying to pass a bill. It's also worth noting that state legislatures, unlike Congress, are often really part-time jobs. There are some state legislatures that get in and get out in less than 2 months. Virginia this year was, I think, an 8-week session. They were done very, very early in the year, and they're through until next year. There are other states that are in all 12 months, Pennsylvania, Michigan, a few like that, that will be in all year long. And then there's lots that are in between. There are some states that only come into session every other year, like Texas and North Dakota, making this an incredibly important year because in a state as big and important as Texas, as Diana will be able to tell us, you don't want to miss an opportunity to move public policy forward because it might be a long time before you get another chance. So, one of the first things we need to know about state advocacy is that we need to be experts not just in one state or one process or one set of decision makers. We've got to be experts in 50 states, 50 processes, 50 sets of decision makers, and often 50 sets of statute, laws, and regulations that overlay any of the policies we're trying to change or appropriations we're trying to secure. So there's a lot of pre-work to do and a lot of expertise that we have to develop kind of on the fly. And we do that often with the help of our advocates, with coalition members, et cetera, to make sure that the voice of the ALS community is really being heard in state houses. Let's move a little bit further down the line. So report cards. Now, there is a link in your chat that Dustin put in a bit ago that will take you to our website and the page where you can find the kind of nice looking PDF report cards for your state. But we're going to go over these in some depth right now and then go through some of the different grades and see where your states might be. As we're looking at this map, you'll notice there are some states that seem to be doing pretty well, some states that leave a lot to be desired. And one of the things you might notice is that there are perhaps some surprises as to which is which. We'll get into that in just a little bit. But, one last thing I want to tell you before I toss it over to Diana and Clark to make some comments as well, is that all the information in these report cards is current as of December. So really, we were looking at laws that had passed, appropriations that had been adopted as of December 2024. So there might be, and in fact, there have been just in the last week, some new laws signed that would change some grades on this map, and they will be put into the report cards for next year as we get the full new landscape of what states have passed which policies. But for now, this is what our rankings look like. So as I toss to this next slide, Diana, could you talk a little bit about how we came up with these mix of policies? Because there's a lot of policies that we try to pursue at the state level, right? So how did we come up with this mix of 5 to focus on for this report card?
Sure. I think if we look at the landscape in general, and we look at what type of laws would make the most impact of people living with ALS, these were the top policy priorities. There's several others that could have been selected, but what made sense is what is the urgency and what is the need right now? When we look at appropriations, Medigap, prior authorization, step therapy, what are the biggest barriers to healthcare for people living with ALS, and how can we resolve and address those issues rather quickly? And these were the ones that came up at the top.
Exactly so. So we're going to get into each of these categories in greater detail in just a moment or two. But just did want to say we did, go through a fairly rigorous process throughout the fall and winter of doing research, working with coalition partners, digging into the archives of the state compiled statutes and code to see, where each state should land within each of these policy priorities. And often this is a tough thing to figure out, right? Because not every policy, not every law looks exactly the same. So there were some kind of subjective moments here where we had to decide, does a state deserve an A? Does it deserve a B? Is it maybe a C? Depending on some of the vagaries of these individual laws. So thanks, Diana, thanks, Clark, and thanks to the rest of our state advocacy team that couldn't be with us on the call today because we've got one of our team members delivering a testimony for an appropriations at an appropriations hearing in Ohio, and another team member leading a lobby day in Albany in the great state of New York. So thanks to them for doing that work. Now let's move a little bit along to some of the outcomes. It really wasn't a surprise that there was a lot of variability, but where some of the states landed was a little bit surprising. Clark, do you want to talk a little bit about the kind of some of the surprises or unexpected results that we saw?
Yeah, thank you, Alex. That's a really good point. And as you look through the report card and you look over the list of states, as a policy professional, I try to look for trends in the different states and where they landed. And, the only trend that's obvious to me is that there really is no trend. Um, I think New York is a great example of a state that, really just hits on all cylinders and is, doing all the things that the ALS community needs it to do to make to reach our goals. And then unfortunately, as you can see here, the state of Utah, a state actually near and dear to my heart, that's where my family's from, not doing so well. The one thing I can tell you, though, in talking to advocates from places like Utah, is that there's an opportunity to do education there. A lot of the decision makers there feel like they're really surprised when this report card was brought to their attention, and they thought for a long time that they were doing the right things by their constituents. And when we get into the details and talk about specifics, they're really shocked to realize, wow, you're right, we don't do that. And so when you look at some of these states that have not the best grades, I really look at it as an opportunity to do education. And I don't think that there's any state that just doesn't prioritize these issues. I think it's just time for us and for our community to really get a hold of those decision makers and talk about our issues with them.
It is a really good point to make because, there are certainly some policies, some of these policies that are real fights because there are industries and moneyed interests on the other side trying to stop it. But there are also things that just haven't come up yet. There are things that probably would pass with a little bit of push, but because we are a smaller community, and because if you're in a part-time legislature where you've got a day job, you're working most days of the week, and then you're commuting down to the state capitol for votes a couple of days a week, and that's maybe 2 or 3 months out of your year. You're serving on a number of different committees, none of which are, or almost none of which are really, in line with your professional experience. You're trying to learn a little bit of everything on the fly. It can be very hard to become expert enough to really push through. Now, Diana, you were a state representative in Texas. That process had to be a challenge for you. Do you want to talk about that a little bit?
Sure. So when I was in elected office, there was definitely a lot of opportunities to learn different key issues. And also, I think the great thing was I knew going in what were the key topics I wanted to address. But of course, when you are a freshman, there's only so many things you could do, and also your staff is equipped to do as well. And some may have the experience, some may not, and they're learning as well. And I think in some states where they do have staff, meeting and talking with a staff member is just as good as a lawmaker, and understanding that making sure the staff members are educated just as much as the lawmaker is important for them to understand the issue, because most times those staff members are pushing the bill just as much as the lawmaker is. And that's one key takeaway, I would say. And in some states where they have no staff, having that personal relationship with those elected leaders, it's monumental. It can make a difference between having a bill heard in committee or not.
Yeah, I think it's a great point that staff really are impactful here. Now, I don't want to stop the conversation, but I did want to switch to this next slide because this is going to take a little bit of explanation, and probably this is where you kind of lean further into the screen and see exactly how your state did. So this is the full listing of the grades that we gave each state in each of these categories: appropriations, Medigap, prior authorization, step therapy, and copay accumulators, and then their cumulative grade point average. And it's worth mentioning that, some of these copay accumulators, for instance, essentially you either got an A or you got an F. Whereas others, prior authorization being a great example, there are many more levels of detail in that policy where you could have ended up with a C, a D, a B, an A. There's a lot of different layers there. So with that variability, I'll leave this slide on the screen for a moment or two so you can see how your state and maybe some neighboring states are faring, and especially with an eye towards that GPA towards in that last column there. But Clark, I saw you come off. Do you have something you wanted to add in on that?
Well, I was just going to piggyback on what Diana mentioned about relationships. And, in a lot of these smaller states, she's absolutely right. Just being present really can make a difference. I know that in my work in Alaska, for example, Alaska's state capital, Juneau, is, there's only two ways in, right? By airplane and by boat. So it's fairly difficult for people to get in. But by us as an organization making the effort to be there in person, we have really made a lot of great relationships with legislators, and our door is always open when I'm walking the halls of the Alaska Capitol, and they treat me like I'm an old friend there just because I make the effort to show up, which a lot of folks from the lower 48 don't bother to do. And a lot of these other small state capitals, like New Mexico and Santa Fe and um, Carson City, Nevada, they're the same way. They love to see their constituents, and if you have an opportunity to go to your state capital and to meet with your elected official, I would highly recommend that you do that. Introduce yourself and talk about your issues.
Yeah, if we were doing this webinar in a great big room, I would ask everyone to raise your hand if you know the names of any of your state elected officials, right? Your state rep, your state senator. And when I've done this in the past, I got to say, not too many hands go up. So, Clark makes a great point. Getting down to your state house, getting down to a local event where your elected officials might be, just answering the door during election year when they're going door to door, canvassing and knocking doors, can be a great opportunity to make that connection. And, frankly, there are not a lot of other organizations advocating at the state level when it comes to rare diseases in general or ALS in particular. There are lots, as well there should be, of orgs that we ally with all the time advocating for the ALS community at the federal level. But at the state level, it's a little more lonely in the rare disease space and in the ALS space. So there's a little bit more of an opportunity to be the one person or one of the only people from the ALS world that your lawmaker might interact with all year long or might hear from all year long. So now I'm going to zoom ahead one more slide. So appropriations. This is the first kind of deep dive we're going to do. And as we talk about appropriations, we're talking about a few different things. We're talking about trying to secure state funding for either ALS care services, ALS research, or ALS clinics. Now, when we are looking at state funding, it's important to know that a fair amount of state funding started its life as federal funding that then got passed down to states. That's how a lot of your tax dollars work. They go to the federal government, the federal government programs them out in one way or another, sends them to states, and then the states get to spend them. States also have something unique, which is that most of them have to pass balanced budgets. They can't deficit spend. The federal government, as I'm sure many of you are aware, can go into the red just as deep as they'd like, many trillions of dollars at the moment. And they're able to do that and keep their appropriations moving forward. Most states can't do that. They have to pass balanced budgets. So their budgets are necessarily a lot more lean. And what they spend their money on tends to be a different basket of services than the federal government spends. The states spend most of their money on education, K through 12, as well as higher ed. They spend their money on Medicaid. They spend their money on, other state-run services. Something that they don't tend to spend a ton of money on is public health or even family services, social services. So the pie that you're trying to take a slice from when it comes to state budgets is already going to be smaller than the federal government's budget by a good ways. Within that, the slice of that smaller pie that is, theoretically going to be allocated to public health is going to be smaller still. And then we're trying to get a sliver of that smaller slice of pie. So it is, even though a state budget might be 50, 60, $100 billion, and you think that's a lot of money every year, which it is, there's a relatively small amount of that which is kind of accessible to the public health community. Now, as we're then trying to get some of those dollars, really it varies from state to state. In some states, we're able to secure direct appropriations where a state might put a line item in the budget saying $1 million in the next fiscal year will go to the ALS Association to provide ALS care services, or $750,000 will go to these 3 state-affiliated hospitals that run ALS clinics for the maintenance of their clinics. Sometimes it's direct like that. Sometimes the state funding is a little more opaque, and you've got to go through then a grant application process. And all that's to say this, there is no one-size-fits-all appropriation. What we try to do is start with a conversation with our care service team, with our clinic support team, and say, what do you need? What would state dollars be able to do, be able to accomplish for the ALS community in this state? Do we need more eye gaze speech devices to lend out? Do we need money to start a ramp program? Do we need extra cash to help folks make it to clinic? There are a lot of different things that we try to fund always for free via care services that we always run up against the limits of our budget as a nonprofit. State dollars can help bridge some of that gap, allow us to say yes more often, and be forced to say no a little bit less often. But we've got to make that case to lawmakers, not just that it's the right thing to do insofar as it's a worthy cause, but that it's a little bit more worthy, a little bit more right in a way to do than many of the other worthy causes that are also trying to get a piece of that state budget. So it can be tricky to get that initial appropriation, but it is incredibly important to do. Once you get that initial appropriation, which is the hardest part, the second hardest part is getting the first renewal of that appropriation. The next budget cycle, once you're in there for 2 budgets, then there's a little bit of muscle memory that comes into place. It's never easy to get year 3, year 4, year 10 of an appropriation, but it gets more easy as more legislators, get to know what the program does and take some ownership of it and are able to support it to a little bit of a greater degree. As we're looking at appropriations, Diana, I know you've been working on a few this year in Texas and Oklahoma and elsewhere. Can you talk a little bit about some of your efforts this year?
Sure. I'd love to start with Oklahoma. I think I'm really excited about Michael and Wendy and their leadership, and also the Oklahoma Advocacy Committee. What started as just a response of understanding that there was a small group of people who were part of the Oklahoma Leadership Council who just said, we want to make sure care services is funded, that we have the durable medical equipment, we have the grants accessible to us. We don't know what's going to happen with this economy. And I think the lessons we learned in the previous session where we tried to get a grant created and at the umpteenth hour, it failed. We knew this session we had to try again and have a different approach. And the great thing is that there was some groundwork already laid. This go around, the grant was created, it was passed into law, but now that the grant is passed, we have to fund the grant. So that's a separate request. And not all states function the same way. For instance, in Texas, it is not even necessarily a line item in the budget. It's part of a bigger package that is discussed during a conference committee. A conference committee happens after the budget has gone through committee, the House, the Senate. It's been debated on the House floor, discussed on the Senate floor, and you have a core group of individuals from the House and Senate convening to discuss what's the final budget going to look like. And of course, being part of those conversations, it doesn't happen when session starts. It happens a year in advance. So having the advocates in place to have those conversations early on is crucial to making sure you can get something fulfilled.
That's a great point. And it raises the issue of, making sure that we're active at every step of the process. On the left side of the screen there, you'll see some of the procedural steps that you have to go through. And those are all opportunities to get funding inserted into the budget, and also opportunities potentially to have it stripped out. One of the things that we're seeing this year, as there are new economic headwinds over the last, really month to 6 weeks, is we're in a bit of a greater zone of danger with regard to appropriations. We saw For instance, unfortunately, we had money within the South Carolina budget that was just about through. It was to that conference committee, to that penultimate step. And then because the economic forecasts for the country and for the state started to take a real turn for the worse in early April, the state budget office there revised their revenue estimates, and the lawmakers realized, oh, we need to cut. So what did they do? They cut all $700 million of the state's legislative earmarks, everything from public health programs like our $500,000 that was until then in that budget, right through to police station construction assistance. So things that you would think are, pretty sacrosanct within a state budget, they also got cut. And again, it's because of this 11th hour headwind. We saw something similar in Indiana, where we were within the budget and the governor's request, the version of the bill that passed the House, the version of the bill that passed the Senate. And unfortunately, then within the last 36 hours of session, they got a new state revenue estimate that said, basically, remember the revenue estimate we gave you a month ago? Well, here's another one, and this one is $2.5 billion lower than the one a month ago. And so they had to go out and cut $2.5 billion worth of add-ons to the budget. And again, when we're talking about the public health portion of the budget, there's not that much to go around. So it's one of these that we need to be active in every phase of this and aware that, it's going to be, state funding can be a little bit like the tide. When the tide is in, it can be a little easier to secure those appropriations, to maybe plus up and grow those appropriations. When the tide's going out, we've got to work hard to protect those appropriations and to try to keep them from being downsized. Now, for every bit of hard news, there's also been great news. Missouri passed a budget that included our funding, funding for ALS just over the weekend. Alabama did so last week. So there's a lot of good news as well. But for most states, the appropriations fight is ongoing and will be ongoing for quite a while longer this year. So this is a great area to get involved. Just as you can see photos of other ALS advocates doing, many of these just in the last week or two. And in fact, again, there's folks in the state houses and in Ohio and New York today. Last week, we had events in California, in Pennsylvania, in Michigan. Diana, you led an event in Oklahoma over the weekend previous. So this is definitely a busy time for appropriation season. So getting down to our next big issue, Medigap. So you may or may not have heard of Medigap, but here's the quick version. For anyone who is on traditional Medicare as their primary insurance, you will well know that Medicare will cover about 80% of your costs, but they will leave you to cover 20% of those costs. Medigap, or Medicare supplemental insurance, is private insurance that is federally and state regulated that can then cover that gap. So you buy a plan from Aetna or Cigna or Humana or something like that, but it's not normal private insurance. It's heavily regulated insurance that has to conform to federal standards for what Medigap plans must cover. Now, here's the rub. If you're on Medicare because you turned 65 and applied for Medicare like so many millions of Americans do every year, you are automatically eligible for price-controlled Medigap. So during the 6-month enrollment window, after you sign up for Medicare, you can go and buy Medigap insurance, sign up for a monthly plan, and the insurance carriers have to offer you a really good rate. They cannot charge you an arm and a leg. They've got to charge you a very preferred rate for what your monthly premium is going to be. If, however, you miss that 6-month window when you turn 65, or importantly, if you're on Medicare and are under the age of 65, like someone with ALS can be, and again, there are only 2 medical conditions that allow an under 65-year-old to instantly sign up for Medicare. It's end-stage renal disease and ALS. So if you are an ALS patient under the age of 65, you can instantly get on Medicare, but there's no guarantee that you're going to be able to buy Medigap. In some states, there's no protection. So insurance carriers won't even sell you a plan. They'll just refuse to sell you a plan. In other states, there is some protection where states will say, okay, insurance carriers, you have to offer a plan for sale to the under 65 community. But what they don't tell you is that those carriers can charge whatever they want. So what's that do? Well, here's an example of what that does. We were working on one of these bills that didn't quite get over the finish line. It passed the House, it got stuck in the Senate, but we'll be back next year in Georgia earlier this year. And as you can see, this is the same exact Medigap plan for someone who is, demographically the same person living in the same zip code in Georgia. But one of these on the left is for someone who's 64 years old, and the other on the right is for someone who's 65 years old. Now, what does that difference make? Well, the 65-year-old gets the benefit of those affordable plans and pays $154 a month. The under 65-year-old pays $1,579 a month for the same plan. So that can be the difference of having these state level legal protections or not having these state level legal protections for Medigap. And that's why we're working so hard to, make sure that more and more states, and it's up to 17 now and growing, protect access to affordable Medigap plans for the full under 65 community, and ideally allow everyone on Medigap under and over 65 some portability so that they can switch between carriers. So if you're unhappy with Humana because they've been raising your rates by 10% every year and you want to switch over to Aetna, you can do that, but only if we pass a law saying that you're allowed to do that. So those are the Medigap bills we're talking about when we talk about Medigap. Now, Diana, I know you've been working on Medigap in Texas quite a bit, so let me toss it to you for your thoughts on that campaign and where we stand in Lone Star State right now.
Yes, so never in my wildest dreams did I think I would be leading a Medigap coalition of organizations who are committed to making sure that a Medigap bill is passed in Texas. What happened was we started nearly a year ago with a group of patient advocate groups, whether it's American Kidney Fund, Dialysis Patient Council, and our organization, our coalition began to grow. And I knew early on, by connecting with some lawmakers in Houston, the conversation evolved into we would really love to get this passed. ALS is personal to me. And this lawmaker introduced me to a family member of hers who was diagnosed. It was a brother-in-law. And she says, but I can't pass it across the finish line. I'm a Democrat, and this is Texas. And in order to get this bill passed, we need a Republican author. I'll start the legwork on it. And she committed State Representative Ann Johnson in Texas. And her sister, Sissy, and her brother-in-law, Chris, came to the Capitol to testify. And of course, when you're diagnosed with ALS, it affects your speech. It affects how you walk. He was in a wheelchair, and as he was trying to give a testimony in the House, it became very emotional for him. And I think for everyone that was behind the dais that were state representatives, they had never seen ALS affect someone, and this was the first time they saw it. There was not a dry eye in that room. People we thought who would be naturally against the bill, just because they may be in favor of insurers or anything like that, they quickly said, we're going to help you pass this bill. And when it came to the House floor, they renamed the bill the Chris Larkin Act in Texas. And while this bill is still moving through the process, it'll be heard in the Senate. I think the key takeaway of this is having a coalition of organizations that will also be your strong arm and be talking to lawmakers just as much as we were, and not just having our advocates, but I think having lawmakers who just understand, who are a little bit more seasoned, understand the process, and understand the political ramifications of how this bill could play out if they file it versus somebody else, and making sure that we had a team of lawmakers around this to get this passed. That was really key to making sure that we had the right set of authors so the bill could even get this far. Because in a previous session, we didn't have a team of coalitions. The ALS Association just testified on this bill. Our coalition is meeting weekly just to get this bill passed, and we've been meeting weekly for quite some time, for several months now.
And it really is such an important point that, not only do we need coalition partners, but we also need that voice, that face to embody this issue, right? Just like Chris did in his doing in Texas. I'm looking at the pictures on the left, at the bottom there, Katie Adams, who I got the pleasure of working with in Kentucky on a bill that we were able to pass. And above it, Angelina Fanous. Angelina is a young woman who was diagnosed at 29, now lives just outside Cleveland, Ohio. And she's working with us in Ohio, where we're trying to move a Medigap bill. And earlier this spring, I had the pleasure to go in and testify on that bill. Angelina was trying to be there that day, but it logistically was just too tough. But what I was able to do with her help and assent was to read some of her statement out loud to the committee, and it was, I think, powerful to the members of that committee, even though she wasn't physically able to be there that day. And I know she plans to go to the State House later this month. We were still able to work together to get her voice, her story, her words in front of those committee members at that committee. And then, on top of that, she was able to work with members of her local media. You can see a TV story. And in fact, they then did a follow-up. They've done a couple of TV spots in the Cleveland market on Angelina and her fight for this bill. So my ask to everybody watching, if you are, or if you know someone who is under the age of 65 on Medigap, or I'm sorry, on Medicare or Medicare Advantage as your primary insurer, and you're living in a state that doesn't have a good grade for Medigap, that we need better Medigap protections for you, reach out. There'll be a contact email at the end of this. Reach out and let us know, because we need, more voices, more faces, more stories of why this matters to cut through the clutter of a legislative agenda. A lot of folks think that your biggest challenge in trying to pass a bill is opposition, right? And sometimes opposition is a challenge, but I swear the biggest challenge at the state level is the calendar. State sessions tend to be short. There are not that many committee days. When they actually have hearings, they might have room for 3 or 4, maybe 5 bills. So over the course of a session, they might hear 20, 30 bills, but they may have had 200 bills referred to them. So most bills don't die because they were voted down. They die because they never got a vote at all. So being able to cut through the clutter of other issues and get our bills not only voted through, but on the calendar, on the agenda at all, can be a challenge. And it's a challenge that, becomes a lot easier with the help and support of advocates. So with that plug, I will move on along, and I will zip through some of the next agenda items a little bit faster.
Hey, Alex, just really quickly,
Oh, please.
I just maybe want to bring to folks' attention, having worked on Medigap in a couple of places, this is one of those really complicated bills that just make legislators' heads swirl because of the complexity of the issue. As Alex mentioned, these are state-regulated products, and many state departments of insurance have resources and staff and volunteers, as I've discovered, that can help folks with ALS that are, confronted with like, okay, which kind of policy should I be purchasing? And you can get a good neutral opinion with some, not the insurance agent pushing you one direction or the other. But yeah, if you find yourself in that position, reach out to your state department of insurance and see if they have a program where they can help you navigate this very complex list of products.
That's a great point, because I don't think I've ever been to a Medigap hearing in any state where at least one lawmaker didn't confuse Medigap for Medicare, for Medicaid. Even amongst members of insurance committees, there's a lot of confusion about this issue. And I got to tell one story here, just because it still makes me both laugh and mad at the same time. We were moving one of these bills last year in Indiana, and we had a terrific sponsor, Senator Kyle Walker. He worked with us very closely. We had a good coalition working on it, and we had this bill moving forward, and it was moving to the Senate Health Committee. But there was one member of that committee, a senator who I suppose I probably shouldn't name, but he's a State Farm agent, and he was dead set against that bill moving. So even though we had the support of, I think, 8 of the 9 members of the committee, certainly, including the chairman, this one member of the committee kept saying, guys, you gotta listen to me. And this is Indiana. So there's 9 members of the committee, and it's 7 Republicans and 2 Democrats. And he was a very senior Republican on the committee. And he said to his committee members, friends, I am the only one on this committee who works in insurance for a living. You've got to believe me. Don't believe them. They're telling you things, but just trust me. This is a bad bill. Don't do it. Don't do it. Don't do it. And he basically tried to stand on the tracks, put his arms wide, and not let this thing through. But because we had done our homework, because we had data, we had actuarial reports, we had examples from other states, we had every question answered twice. When it finally got time to the vote, and this one senator made one last push saying, and this is a paraphrase, but it's pretty close to a quote, members of this committee, if you don't like me at all, if you don't trust me at all, then fine, pass this bill. But if you think I know what I'm talking about, then you need to defeat this bill with me. And at that point, the committee chairman had had enough, and he said, Mike, you can't do that. You can't ask people to decide whether you're dumb or just a liar. You've got to let them vote this bill through. And that's exactly what they did. So even when we had someone from insurance who was pushing real hard against one of our bills, because we had done so much groundwork, to Diana's point, right, to Clark's point of going in, meeting with members, not the day of the committee hearing, not the week before that, but months and months before that, even a year before that, because we had, bushwhacked our way through all the confusion that's inherent to trying to move an insurance reform bill. When we got to that committee hearing, everybody else on that committee knew what the bill would do. They knew what it wouldn't do, and they were willing to push it through, and we were able to sign it into law. So really, again, it is all of that pre-work in advance of the committee hearing that makes the difference. And it is the volunteers and advocates that allow us to make that pre-work happen, that make it compelling, that are the gas in the car that makes that go. With that, let me zip along to our next item here. So prior authorization reform. If you think Medigap and Medicare supplemental insurance is confusing, let me introduce you to prior auth reform. I am not going to go through the American Medical Association's several dozen principles on prior auth, or their 8 categories of potential reform, or the 5 subcategories that we focused on, because it will make all of your heads spin and everybody will drop off this Zoom. What I will say is this: prior authorization exists to allow insurance companies to say no. Right now, it does probably play a real role in making sure that appropriate care is delivered. But for our population, for folks with ALS that are under, significant care from their medical professionals, what prior authorization most of the time does is give an insurance company the ability to say, no, we don't want to cover that. We don't want to cover that service. We don't want to cover that procedure. We don't want to cover that medication. We don't want to cover that piece of equipment. And if they can't say no outright, it gives them the opportunity to drag out the process by which they say yes, to say no until there's an internal review and an internal appeal, et cetera, et cetera, et cetera. What reforming the prior authorization process can do is short circuit some of those delay tactics. Make it so that instead of having an open-ended deadline for when an insurance company will actually get back to the doctor with the answer of whether or not the insurance carrier will pay for that test that the doctor just ordered, they might have a very tight turnaround, 48 hours or something like that, by which they have to get back. And that is a big improvement. That speeds things up a lot. Prior authorization reform can also have things that say if a procedure, a service, a piece of equipment is approved like more than 90% of the time, it should be automatically approved and then can be reviewed on the other end. Basically, putting the onus on the insurance company to prove why it shouldn't be approved, as opposed to putting the onus on the patient, on their caregiver, on their medical professional to prove why it should be approved. So there's a whole basket of different laws that all fall within the rubric of reforming prior authorization. There's a lot of variability. There's a lot of room to improve. Even states that are doing pretty well, there's ways that they can improve. The ones that aren't doing so well yet, lots of opportunities, lots of theoretically low-hanging fruit for them to move forward. These are complicated issues. There's a lot of stakeholders involved, but they are important at the back end, and you'll hopefully notice it with fewer headaches, fewer hours spent on hold with your insurance company, and fewer frustrated doctors and nurses as they try to get things approved. I'm going to zip on to the next, and then we'll start the conversation back up a little bit. Step therapy and fail first. So in a nutshell, what this means is that an insurance company might say, before we will approve this medication or this procedure or this device that your doctor has just ordered for you, we're going to require you to try something, to take something that is similar but cheaper. And you have to prove that that won't work for you before you can get the thing that your doctor actually ordered for you. What does this look like in practice? It could be, oh, prove that you can't use the world's cheapest motorized wheelchair before we'll approve the actual wheelchair you need. Prove that you can't use this generic, slightly related medicine instead of the actual specifically designed for ALS medicine that you might need. Or even in some cases, prove that a CPAP machine won't work to keep you breathing when your doctor has just ordered a non-invasive ventilator for you. So, Diana, I know you've been doing a fair amount of work on this. Do you want to jump in on this one?
Sure. So in Louisiana and in Arkansas, we passed step therapy bills. And in Louisiana, we were able to actually participate and team up with Team Gleason and Viamed on this bill, on a bill that helped people with non-invasive ventilators. It was just far too often, people will be given a CPAP machine and they have to fail that first in order to get their non-invasive ventilator. And fortunately, we've made some strides in Louisiana and Arkansas on those bills. And those are probably don't get the biggest headlines, but that's some necessary work that does need to be done because that directly affects people living with ALS.
Mhm. And I should mention some of the green states here, a lot of the information that was publicly available with regard to fail first and step therapy is specific to medication, right? Because most fail first step therapy protocols are aimed at medications, taking this drug instead of that drug. We're in the rare circumstance with things like non-invasive ventilators where there's durable medical equipment that also can fall into this step therapy trap. So, even as we're looking at this screen and seeing a lot of dark green states, some of these we might end up changing next year to kind of a light green or a yellow or something like that, because they might need that additional language to clarify that the step therapy laws that are already on their books do include things like non-invasive ventilators. Then let's do one more here, and then we'll zip into a couple of issues that we're looking at as potential new ones for next year. But before we get to that, let's talk copay accumulators. And Clark, I'm just going to hand this one over to you because you've been doing a lot of work in this area.
Yes, thanks, Alex. As many of you know, ALS drugs are extremely expensive, and drugs just in general are. And so there's a number of programs out there by pharmaceutical companies or nonprofit organizations that will basically help offset the cost of these drugs by helping patients pay for their copays um, and they're making payments towards their deductible. And so in a lot of states, insurance companies will not allow those payments to count towards somebody's yearly deductible. And that's because honestly, it's kind of a fight, and we're caught in the patients are caught in the middle of this, but it's a fight between insurance companies and pharmaceutical companies. And so what this legislation does is just basically says that if a third party, regardless of who that third party, helps a patient with their copays, then that needs to count towards their deductible. And so this is a growing issue that we've been working on across the country. I've worked on it in Colorado, in Oregon. It took 5 years in Oregon to pass. Been working on it in Utah a number of years. And really, the challenge is here is that in states that have really, really strong insurance lobbies, they do not like this. And in some places, one of the reasons why it took a long time to pass in Oregon, quite honestly, is because the Oregon legislature doesn't like the pharmaceutical industry. And so, oftentimes our community gets caught in the crossfire between, legislators' disdain for insurance companies and the pharmaceutical industry. And so we need to, bring that attention to the legislators and say, hey, look, we're a vulnerable community, and we don't need to, please take, your differences and your issues with those two industries and have that discussion in a different forum, but don't penalize our folks. And so that's really what we're doing is we're trying to, spread awareness around this. And, honestly, the story that I'd love to tell people about, this example of what's going on is in Utah, where literally we've had hearings after hearing for the last couple of years on this, and most of the legislature is really on board with supporting our position on this. But the Speaker of the Utah House um, is really, really good friends with the head of the Utah insurance lobby, and they ride horses together and they hunt together, and that's really what it's kind of come down to. And unfortunately, our community suffers from thinking like that.
It really can come down to something as simple as that, and that's why having additional personal connections on our side can be so impactful. And before we leave this slide, I'll say one last thing. Just in the last week, we've seen a new copay accumulator law signed in Indiana. So any Hoosiers on this call, you're now gone from red to green for this one. All right, so those are the 5 policies that we put on this year's card, but they're not the only 5 policies we work on, right? They were ones that were broad enough that, that there was a good variability across the country, and then they were impactful enough that they were worth our time, but they're not the only one. So we're going to briefly go through a few other issues that we're looking to work on that may or may not make it to next year's report card, but we're going to continue to work on in any event. The first, Genetic Testing Protection Act. Now, if your family is a carrier or might be a carrier of one of the genetic forms of ALS, you might want to go and get a genetic test to see if you, in fact, carry that gene. But if you do, you also go and take that test with the knowledge that a life insurer, a long-term care insurer, might use the fact that you took that test as a reason to not offer you any life insurance, to refuse to sell you life insurance. And this is true for the ALS community. It's true for the cancer community and many others, where the very fact of going and getting yourself tested, being proactive about your health by taking a genetic test, can have the unintended consequences of having insurers then ban you from their products. That's not fair. The state of Florida has already passed a great law on this, as have the countries of Canada, the UK, and Australia. And there's a lot of other states in the United States that have taken incremental steps towards the solution we want. The latest being Maryland, which you can see in the picture, just signed a law on this just last week, with a big incremental step in the right direction. It didn't quite get all the way to where we wanted. The final version of the bill was amended a few times. We didn't get everything we wanted. The insurance industry didn't get everything they wanted. It was kind of a meet in the middle, but it's a step in the right direction. And we're going to keep pushing there and elsewhere for genetic testing protection. A few other things, telehealth. Clark, do you want to talk just briefly about telehealth and why we're working on it?
Yeah, so just briefly, as many of you know, telehealth really took off as a result of the COVID. People having to get access to their providers throughout the COVID time, and it's proved to be a really effective way for people to see their providers. And in places like Alaska, Montana, Oregon, big Western states where there's few ALS providers, and if there are some in your state, you have to drive 2, 3, 4, 5 hours to get to them. Telehealth is a great way to help address access to providers, and so we are really working hard to make sure that telehealth continues to grow, whether it be through payment reimbursement parity, which would basically means that a telehealth call would be reimbursed at the same rate as an in-person call would be, as well as also working on policies that guarantee or make sure that telehealth visits have the same quality components that a in-person visit does. And so we really see this as a technology that can make a big change in the quality of life of our folks. Can save you from having to drive an hour or two just for a 10-minute visit with your neurologist. If you can do that via telehealth, we feel like that's a great thing. And so we're really working hard on this type of legislation.
Well, thank you. It is a very important thing that we need to keep an eye on everywhere. And I realize we're getting close on time, and I want to leave time for Dustin to talk about how to engage and then for any questions. So I'm just going to zip through, and I'm not going to belabor each of these. You can see we're also looking at and working on caregiver support programs, Protecting Medicaid is certainly in the news. I know that it's not a huge percentage of folks with ALS or on Medicaid, but a fair number are dual enrolled. So it's something we want to make sure stays strong enough to support those who need it. Medical debt is an issue that's becoming more prominent in state houses across the country, and we want to make sure the ALS community is included in those conversations. And then biomarkers, we've worked on a number of bills in different states that will help ensure that once biomarker tests for ALS hopefully become available, and there's a ton of promising research in this area, that insurers will actually have to cover it, because it would be no good if there was a scientific and medical breakthrough and biomarker tests, dispositive tests for ALS were on the market, but they were too expensive and no one could get them because insurers were allowed to just refuse to cover. So we're trying to be proactive about that as well. And there's a picture of a lobby day just last week in Lansing. But now I'm going to hand it over to Dustin to talk about how you all can get involved.
Awesome. Thanks, Alex. And thanks everyone for joining us today. As you can see, we have an incredible state advocacy team, very knowledgeable on things going across the country on many different issues. And I've learned a lot just being here today, so I hope you have as well. But they need our support. They need everyone on the call, and folks across the country join with us to really harness that power to kind of implement a lot of these changes and things that we need to happen in state houses across the country. So if you haven't already, join our ALS Advocate Network. You can scan that code. You can go to the link that I just put in the chat at als.org/advocate, or you can text ALS to 1-855-469-2621. So let's go to the next slide. When you do that, you'll be able to sign up here if you haven't already. We just need your first and last name and your email, and then of course your home address. That is very important. That's the one little sticking point some folks get to, especially on this form. It's going to be a drop down when you do it. So that is so that our system can recognize it and then match you with all of your legislators going forward. And if you want, you can add your cell phone and you can actually get text messages from us. But that's not required. But if you would like that, we send very limited number of texts on the most pressing issues out there, but you can join that as well. And then you put your connection to ALS on there as well. Next slide. When you join, you'll be taken to this Advocacy Action Center. So some of you who have already taken action, if you go to that link, you go directly to this page. There's a lot of information that we have on both state, federal, and other advocacy resources. But for today, you can click that Take Action button, and it would list all of the alerts that we have, both federal and state alerts across the country. So if you have a specific state alert in your state, it would show up there. So I just want to highlight that for folks. So next slide. It's in the chat. I'm going to put in, we have a couple of alerts we want to highlight. The first is our ALS Awareness Month alert. And this goes at every level of government, asking lawmakers to recognize May as ALS Awareness Month. So with this, you'll be able to kind of customize it, add your own story. It's a lengthy alert because we even put in a template proclamation at the end that's customized to that specific target as well. So you will go through there, you can scroll and add it in there, and just make sure that you hit submit selected letters at the bottom. That's how you know you're done, that it's been sent. And we've had really great pickup from advocates. However, if we have anyone from the state of Wyoming, we could really use your assistance. So Wyoming, if you're on the call, please take this action. We need a couple more from Wyoming if we can. And then next slide, please. And because we have had a few thousand advocates take that already, I wanted to provide this other new action opportunity where you can record your story. With this, you can record up to 5 minutes. You have the ability to preview it before you submit it to us. So there's some safeguards in there. And then you can also type part of your story in a message as well. So that's the second alert that we have there. That's brand new. And so this is one I wanted to highlight for you all. You can tell about your specific story or any specific issues that you've heard about today that you want to specialize in. You can share why you're an advocate, but these are really, really great. So if you can record your story and send it along, we'd love to highlight it. Next slide. Also, so if you want to get in contact with any of us, you can reach us at advocacy@als.org as our email address. I actually get to handle that email box, so I make sure it goes out to whoever it needs to go. So feel free to reach out to us there. And I think next slide is questions.
Okay, great. And if you wouldn't mind just putting the slide with the QR code up while we're going through questions, there were a couple people asking for that just to be up so they have time to scan it if they want to. Okay, perfect. And we got a lot of questions. So, thank you for the great presentation. I'm going to jump right into the questions. We'll go a little over. That's all right. And so I'm going to jump right into it. The first question, my state house is in walking distance from my home. If I could schedule a meeting with my representatives, would the advocacy team be willing to help prepare me with talking points that I could use?
100% yes.
Okay. And would that just be a matter of reaching out to you via email?
Reach out to that to the address that you just saw. I think it was advocacy@als.org. And then we'll match you up with the person from our team. And it might be someone on the screen. It might be someone who wasn't able to join us on today's webinar. And they will know the details of what specifically we're pushing for in your state and what messages are most timely and most impactful for your electeds. And we'll go from there.
Okay. And I know you shared the report card grades and a link to that. Is there anywhere that has the data behind that, or what went into making those grades?
Yeah, it was pulled from a number of different sources. I think if it's not on the site, we'll have to make sure we do put all the links on there. Because yes, it was pulled from several different reports and then some kind of spot by spot information pulls from specific states.
Wonderful. So if a state does not perform well on the report cards, how does that affect the ALS Association's approach to that state? And is there anything that the individuals today can do in those states to help?
Sure. So we approach campaigns every year as we're doing our planning in advance of session, in a couple of ways. One is areas of greatest need, right? So for all the campaigns that are on the report cards, and then the many that didn't have room to add to the report cards, which do we think are the most impactful, would be the most helpful to that community? That is then overlaid with another view, which is to say, what will the market bear? What's the opportunity right now? If we're trying to move an appropriation, but the state is running a multi-billion-dollar budget deficit, that is really running into the wind. That's going to be tough. On the other hand, if the budget situation is suddenly rosier than it's been in years, that might be the right year to push on appropriation. So it's always a matter of, what are the needs, and then what are the opportunities, and then what resources do we can we bring to bear? And we normally do that planning through the summer and fall, getting ready for spring session.
Great. This question was for states with better report card scores. What do you think factors into that? Is it a matter of more experienced advocates, more money going into the state? Can you speak on that at all?
Sure. It's a few different things. Money is certainly part of it. Active advocates, I think, is an incredibly important part. One of the things that's a bit of an X factor here, the ALS Association has been around for a long time, but our state advocacy team has been around for 3 years, right? We are a relatively new team. Previous to unification, some state-specific chapters had done some state level advocacy and had made it a internal priority. That's one of the reasons that I think we formed a state advocacy team, as we saw the potential there. And so in some states where they had already been leaning into state advocacy for longer than 3 years, they might have had a bit of a head start and have gotten a little bit further, whereas other states had really never done any state advocacy at all. And we're trying to raise the tide in a lot of state houses all at the same time. We are a relatively small team, so I think both the resource question and then the previous work question factor in there.
Okay. And for states like New York, who scored well pretty much across the board, are there still improvements that can be made? What type of improvements would be targeted for those states who are doing so well?
Sure. Well, our colleague Danielle Spadafora is in Albany today doing a lobby day because, of course, there's more to do. One of the things she's lobbying on is a Genetic Testing Protection Act bill that we're trying to move. Again, not on the report card, but it's one of the things that in the future we think we would like to add to the report card. Frankly, it didn't go on because the entire country would have looked red except for Florida. And that was going to be a place where we want to use this as a motivator for lawmakers. We don't want them to retrench into saying, well, no one else is doing it either, so therefore we can fold our arms and not do it here. So we want there to be a little bit of keeping up with the Joneses when it comes to states. Well, the state next door just passed an appropriation. The state just north of us just passed that bill. And so we need a certain number of states to have moved on something to really make it ripe for a national push. In addition to that, she's trying to move a bill to get rid of the medication only clause within the state's fail first step therapy law, and of course pushing for state appropriations as well. You know, appropriations, they generally have to be re-upped every year. So even if you're at an A this year, you might be at an F next year if a budget doesn't move. So there is always more to do.
Okay, great. Somebody from Louisiana was asking, they'd like to know how they can learn more about these items that you guys are grading, such as the step therapy, so that they can use them in their interactions with insurance companies and legislatures. How can they go about learning more about these topics that you guys are looking at and that you guys are pushing at the state level?
Sure. Well, Diana, Louisiana is one of your states. Do you want to take that one?
Sure, not a problem. I think definitely would love to connect with you. Feel free to email us at the email address for our advocacy, I think at als.org. But also would love to go ahead and make sure that we connect you with your lawmaker or how this could apply with you if you have a care services manager that you're working with, or if you're having a hurdle with your insurance. That's definitely something maybe we could help assist with.
Great. This question was specific to appropriations. What factors into how states score specifically on appropriations? Or is that something you're able to speak on?
Sure. They generally fell into one of three categories. The states that were deep red didn't have any appropriations at all. The states that were in the yellowish range, kind of somewhere around a C, either had an appropriation, but one that was at a very low dollar amount compared to the population of the state. So if you've got 10 million people in your state and you've appropriated $100,000, you might be at a C. Whereas if you've got 5 million people in the state and or a million people in your state and you appropriated $100,000, maybe you'd be at an A. Another factor is states that had appropriated money in the previous cycle where some of the money still remained spendable this fiscal year. Now, one of the tricks with appropriations is, especially first-time appropriations, when the state passes that budget, you theoretically have all this money, but in reality, you then have a lot of hoops you've got to jump through. You've got to start working with the state department that is administering the funds. You've got to become a formal vendor. You've got to jump through hoops in terms of applying for the grant. They've got to build out a grant agreement. In some states, they can get that process done in as little as 6 months. In others, it might take the better part of a year. So if you've got a year's worth of money, but you don't actually get the first dime from the state until 10 months in, chances are you're not going to spend all 12 months worth of money in those last 2 months. Even if they're letting you kind of go back and retroactively invoice for things that you've spent earlier in the fiscal year, likely you're going to end up with some money left over. Now, what some states then do is allow you flexibility. And they say, well, look, we understand we gave you $1 million that was supposed to be over 12 months, but we only gave you 2 months to spend it. So for this year, we're going to let you carry over the balance of whatever you have over to this next fiscal year. And in those situations, they might not appropriate new money in their budget, but you still have state money you're working with from the previous budget. And that tends to happen just after that initial first appropriation because the startup time as a new grantee can be so significant. Once you're through that first appropriation cycle, then it's as smooth as can be in the dollars flow. But that's how you might end up as a C in appropriations.
Great, great. And I'm going to end on this just because we are over on time. I'm just going to remind everybody, if you have questions that weren't answered, they did share that email that you can reach out if you have a question about state advocacy, things of that type. The last question, any advice for getting started with forming a relationship with these lawmakers? I believe Diana had mentioned, for ones that don't have much staff, it can be good to form relationships with the lawmaker themselves. So any advice for getting started with that?
Yeah, I mean, Dustin or Clark, if you want to jump in, go for it. I'll just say briefly, state lawmakers are approachable. You know, if you're going to try to reach out to a member of Congress, I mean, I worked on the Hill for a number of years in DC. And the number of levels of staff between a constituent and an actual member of Congress or a senator was significant. The number of levels of staff at a state level can be very small. I live in Indiana. For where I live, 2 state senators each share 1 staff person between them. So if you want to talk to your senator, you pretty much get on the phone and you call your senator and they call you back. Now, some states have a little bit of a bigger staff footprint, but there's no right way to do it. Just reach out, whether it's sending an email to their general page, the site that they'll have on their state page, or any other way you can get in contact with them and just say, hey, I care about this issue. I'd love to sit down and have a cup of coffee. Especially if time isn't of the essence. If you can say sometime in the next month, they're going to find time to do it, and then you start from there. And the nice thing about short legislative sessions means lots and lots of time for lawmakers back in the district, which should give you lots of opportunities to have that initial meeting and start up that relationship.
Wonderful, wonderful. Well, we are out of time. Once again, I would like to thank our great speakers for that amazing presentation. A couple of reminders. You can view a recording of this webinar on our Care Services webinar page. You can also use this webpage to view all of our past webinars we have hosted, as well as sign up for future webinars. I want to remind you that if you did have a question we didn't answer, you can reach out to our advocacy team at advocacy@als.org. I believe Dustin put that email into our chat. Lastly, a final reminder that you will receive a short survey when we end this webinar that we encourage you to complete. Thank you to everyone who was in attendance today, and thank you again to our great speakers. We hope you have a great rest of your day.